John Jones, who's going to talk to us about DGH bispecific delivery experience. John is a clinical academic working at King's, East Sussex, and with a research lab at Brighton. He set up the BITE pathway at Eastbourne DGH, and John has an interest in SPM as well. John, over to you.
Thank you very much, and thanks for inviting me to speak today. It's sort of almost opposite, really, to Francis, that we don't do any ambulatory bispecific delivery in Eastbourne, and I just wanted to talk through that today. When I looked at a photo of Eastbourne, one of the pictures that came up was our beautiful beach, which is the view that I have from my window, which of course is a complete lie because this is what my view looks like. So this is our team. And good timing, last week we were awarded the Myeloma UK CSEP award, and that's some of our team there. We have 6 consultants, a staff grade and a registrar. We have 4 specialist nurses. They're not all cancer or haematological malignancy specific, they're more attached to each individual consultant. We have a ward, we're quite fortunate, we have 11 side rooms and 2 bays. Each bay has 3 patient beds in it, so we can have 17 inpatients at one time. And we've also got a day unit that's attached to our ward, where we have 18 chairs and 2 side rooms for procedures like line insertion, bone marrows. We do share the day unit with the oncology team as well, but we have quite good capacity for a small hospital, and that's where we are, right down there in the southeast. And fortunately, we have an ITU on site and very close to our ward on the same level, which I think is important, and it was something we were worried about. In terms of the population we serve, I think we're fairly unique. It's somewhere that a lot of people go to retire down on the southeast coast, and so the age group is very heavily skewed to an older demographic, really. So sort of most of the sort of bulk of the population between the age of 55 and 85, and that's only going in one direction, as you can see by the 2023 data. And the elderly dependency ratio is also higher. Some areas actually 6.1. So that means for every 10 working people, there's 6.1 people who are older than working age for the area of Rother, which we serve, but in East Sussex as a whole, 4.6 compared to 3. So I think that gives us a little bit of a unique perspective on T-cell engager treatments in an older group of people. You've seen this in many shapes or form, but I try to keep it updated for my own personal. I sort of read this earlier, and they're not necessarily nice therapeutic options. Of course, some of them aren't overly nice. These are nice, approved therapies. But in terms of what we're talking about, it's the bispecifics, which are, at the moment, elranatamab and teclistamab, which are available for patients who have had 3 prior lines exposed to an IMiD, a proteasome inhibitor, and anti-CD38 antibody. And obviously, I won't talk any more about that. I guess a lot of centres have already got their bispecific timeline up or bispecific pathway up and running, but for some centres that don't, and I've spoken to some people that are thinking about it, this is how we approached it. Quite a long time ago now, 3 years ago, we first of all made sure that our pharmacy had tocilizumab available and that we could actually use it. We have a big rheumatology centre in Eastbourne, and so they did have it in stock. We went round to intensive care and explained that we're going to start using these new drugs that come with CRS and ICANS that are fully reversible but make people look very, very unwell. And the reason we went round there is because we've had a lot of battles over the years with ITU, and you say you've got a myeloma patient who's on their 5th line of therapy, is 78, they're not always that keen to take them. And whereas if we explain to them that actually the side effects that we're seeing are treatment related, we hope they'll be more responsive. And they were very sort of accepting of that, and we've had built a good relationship with their ITU team, although fortunately no one on a bispecific has had to go to ITU, I must add. We educated our ward team and the day unit. We devised an SOP, and I admit, Kate, that I think I stole your SOP from King's at the time and just changed it for Eastbourne. And then we started treating our first patients about 3 years ago. And we've treated more than 20 patients since then. In contrast, our patients stay in hospital for the entire time. We were very worried that we'd be an example of a DGH where it's not how to do, this would all just blow up in our face. And so we keep them for the entire ramp-up dosing, and they stay in typically with us for about 9 days, which is potentially a bit overkill, but it's good for us. So this is a subset of 23 patients which I sort of look back on for this talk. Median prior lines of 5, range actually of 3 to 11, my first mistake, or maybe not. But some been more heavily pre-treated. Median age, as you see, it just goes up, with the biggest block of patients being actually 77 or older. In terms of prior lines of therapy, all of them triple-class refractory, over half of them penta exposed, and that means 2 IMiDs, 2 protease inhibitors, and an anti-CD38 antibody, and almost 40% penta refractory. And a reasonable proportion of high risk, although the definition of high risk is sort of debatable, I guess, or not. And actually, I just wanted to point out as well that about 35% of their patients had extramedullary disease, and that was noted on MRI, and we were actively looking for it in our MDT. I'm not going to go through CRS and ICANS scoring because that's been done very eloquently earlier on, but in terms of what we've noted in our patients, 8 have developed grade 1. We've not had any CRS grade 2 or beyond, and we've not had any ICANS at all, which obviously is reassuring. In terms of our response, I just thought I'd add some real-world data for this group of patients for everyone to look at. The overall response rate's been about 55%, so a little bit less than the trials, which sort of the overall response rate tends to be about 60, 61, 65%, depending on what trial. But there's a good proportion of biochemical CR, and at this heavily pre-treated group of patients, that's good. I also had a case that I just wanted to present. This is a 78-year-old lady who's had quite a lot of treatment for the best part of 10 years, including initially treated on the Cardamom study, and then was sort of coming to the end of treatment options at sort of April time last year. Received elranatamab. Initially, first cycle went okay. Paraprotein dropped a little bit. And prior to this, we'd had a number of patients progress quite rapidly on bispecifics, and we've used all 3 in Eastbourne. So we were thinking, well, it's another patient. But actually, on the second cycle, there's a dramatic drop in the paraprotein, and it's now remained undetectable, and it still is to this day. I also just wanted to focus on the 9 patients that I showed you that had sort of older age group. 77 to 88 is our oldest patient, who actually we treated a week or so ago, and I'll show their case in a second. Median prior lines of 4, again 3 to 9, ECOG of 1 and 2. We do look at the RWG frailty scoring, but it's often categorises people as frail straight away because in our case, if you're over 80, you're going to score a 2 anyway. So we look at comorbidities, and earlier on in our treatment timeline, we wouldn't have entertained treating an 88-year-old. But since we've grown with confidence with the drug, and we share our concerns with the patient, sit down with them, say, look, there is this other treatment available. It comes with the need to come into hospital for 9 days. Some of the older patients are immediately like, I'm not going to hospital. And we say, well, okay, but I think it's important to outline what might be available to your patients. They've stayed in hospital on average 10 days. But CRS again low, about 35% again. A similar sort of progression, about 40% of patients have progressed through treatment. We've got 2 that we're waiting for a response assessment on. And this is the patient, 88-year-old sprightly chap who jogged onto the ward and very enthusiastic. He's been treated for myeloma now for the best part of 20 years, and has done very well on each line of therapy. Even Pomdex had a sort of 2-year time on therapy. Came in, developed a temperature of 38.4. We are always very keen just to start neutropenic sepsis protocol up straight away. We culture, chest X-ray, urine, start antibiotics, and then think later if that was right or not. We don't want to blame CRS for infection, so vice versa. We didn't give any tocilizumab. The temperature settled rapidly, and then just sailed through the rest of the ramp-up dosing, and I think actually should have gone home yesterday. It's been touched on about the infection risk, and clearly, in our older patients who are immune compromised anyway, our immune systems don't work so well as we get older, and particularly like that example there of someone who's had myeloma for nearly 20 years. infection is a real problem, and that is a problem irrespective of whether people respond to the drug or not. And we'll just use this to illustrate it. The non-involved light chain becomes undetectable in responders and non-responders in our experience, illustrating the death of healthy plasma cells. And so we give prophylactic levofloxacin, whether that's right or wrong. It's part of in newly diagnosed patients. The TEAM trial showed some benefits. We do counsel people about tendinopathy, and we might use doxycycline if we're worried about that. But in our early experience, we had a number of patients come into A&E very unwell with sepsis, and so we just felt this was an extra level of security, even if it's just for us. But it seems to be working okay. 5 of the 7 older patients that I talked about, not the other 2 that have just started, but 5 of them have been admitted with infections, mainly pneumonia, including 1 fungal pneumonia. We apply straight away for IVIG if the patient's got an IgG level of 4 or less, or even if they've had recurrent infections on antibiotics. And that's another reason why we get the levofloxacin going straight away. Our panel didn't previously accept cotrimoxazole as an antibiotic, for prophylaxis purposes. And we've got most of our patients who are on long-standing treatment now on IVIG, and they're doing okay. Again, as was mentioned earlier, there are atypical infections that can occur, but we haven't seen that. We don't check for CMV, but if there was someone who was clearly not responding to antimicrobials that you might normally expect them to, then we would do extra testing and think outside the box. And I just wanted to sort of, because of our early engagement with biospecifics, we've now got a number of clinical trials up and running, looking at biospecifics down on the South Coast, which I think is really good for our patient population. If we were to, send them to London for biospecifics, it would exclude a lot of people for sure, and we receive referrals from Brighton and other hospitals for administration of biospecifics. And so, in summary, I think that small hospital administration is viable. I think it has to be done properly, but we've not had any safety concerns really with therapy, but we do have a belt and brace approach, having them in all the time. Everyone must be trained and informed, particularly ITU. I think at the moment, most of the patients have been heavily pre-treated, and as the biospecifics come further down the treatment algorithm, we might see CRS and ICANS sort of incidence changing. But tolerance has been good. We use supportive transfusions, GCSF as required, stop during times of infection, and counsel patients start IVIG as soon as we can. And there's the team again, and thank our team, our patients, and my colleagues at King's who I work closely with, who shared the protocols, etc., to get going. And obviously, any questions at the end.
Thank you very much.